healthcare sector meeting. But we're doing this one a little bit differently. Some of you may have had the chance to participate in our very first physical activity plan special event that was last week, but what we're doing is hosting a second Kansas City Physical Activity Summit. That's going to be September 29th. We'll talk a little bit more about that at the end of this meeting today. But in preparation for that, each of the sectors are hosting special events. So this is a little bit longer than our normal sector meeting, as many of you probably know. And we have been lucky enough to have Dr. Lisa Bailey Davis available for our presentation today. Katie, we go to the next slide for just a second. I'm having chair issues at the moment. So the agenda for today's meeting, we're going to start off with a presentation, and then we'll have a short break. We have a recorded physical activity break that we hope you all join us in. And then after that, we'll give a few updates on the different implementation groups for the healthcare sector, and then talk about where do we go from here? How do we continue advancing the strategies for the healthcare sector so that we create environments to make it easier for Kansas Cityans to be physically active. So what I want to do right now is just share a few housekeeping reminders before we get started. Please include your name in your, please add your name to your picture so we can tell who we have with us this morning. Please be sure to mute yourself during the presentation to avoid echoes and other background noise. You may want to consider changing your view to the presenter view so you can see the person speaking along with the slides versus just my face up there. We will have the presentation available both as slides and as a recording. So if you have to drop out early for any reason, or if you know others that might be interested in this information, we'll be able to share that. And as a result, we're recording this presentation. So keep that in mind as you participate. Closed caption is a new option. It's available to all participants. You may just need to select that option to be enabled if you want or need it this morning or this afternoon. Okay, with that, it looks like everyone has been admitted. Is that right, Katie and Veronica?
That's right.
Okay, thank you so much. So with that, I am going to introduce Dr. Bailey Davis. Dr. Bailey Davis is an associate professor of population health sciences and the associate director of the Center for Obesity and Metabolic Research at Geisinger, a large integrated health system in rural Pennsylvania. She's also a registered dietitian. Dr. Bailey Davis earned a bachelor's degree in nutritional science at Pennsylvania State University. She has a master's degree in nutrition education from Immaculata College and a doctorate in adult education from Penn State. She leads multi-level research for obesity prevention and treatment and has published over 60 related papers. Currently, she's leading a comparative effectiveness trial that compares pediatric care delivery models on obesity prevention. Additionally, her research involves patient-reported outcomes, clinical decision support, predictive modeling, and personal health monitoring data. For example, she led system-wide collection of the Family Nutrition and Physical Activity, FNPA, tool as a patient-reported outcome measure in the electronic medical record at Geisinger to improve the quality of pediatric well child visits and the prevention of obesity. Her research is funded by the National Institute of Health, the Patient-Centered Outcomes Research Institute, and the McGowan Charitable Trust. She's also received funding in the past from Centers for Disease Control and Prevention, the Health Resources and Services Administration, the U.S. Department of Ag, the Robert Wood Johnson Foundation, Merck, Novo Nordisk, and Weight Watchers International. So with that, I want to thank Dr. Bailey Davis for being with us this morning to share her experience. And as I bring up her presentation, I'm going to turn it over to her.
Wonderful. Thank you so much, Shelley. It's a pleasure to be with you and the Kansas City group today to talk about how we are enhancing primary care, pediatric primary care with the Family Nutrition and Physical Activity screening tool at Geisinger. Next slide. Great, thanks. So the objectives for today are for you to be able to identify the points of alignment between your physical activity plan, specifically the strategy for healthcare, and Geisinger systematic FNPA screening, which is Family Nutrition and Physical Activity. FNPA is the way that I will typically address that throughout the presentation, and how we do that in pediatric primary care. And I'm also going to discuss prevention models and outcomes that have been evaluated at Geisinger. Next. So first, to kind of get to alignment, and I think this is kind of like why this may matter to you. So in your plan, you, in strategy 20 of the healthcare sector, healthcare systems should increase the priority of physical activity assessment, advice, and promotion. And some of the tactics or strategies there are to make it normal practice to assess and discuss physical activity at every routine patient encounter, and then to document it in the patient's chart. And then also to integrate a physical activity plan into every routine patient encounter and document it in the patient's chart. So at Geisinger, we didn't have a plan per se, but I will get to that in the next slide. So as it relates to the National Physical Activity Plan and your plan, that kind of overarching objective is there. So what we're doing is that we are, for children ages 2 to 12 years, they are screened and assessed for nutrition and physical activity risk behaviors at every wild child visit, and this is documented in the child's EMR. We do have preventive personalized counseling that is provided by the primary care providers, and plans are documented in the child's EMR. And also our exercise counseling is documented as a healthcare quality measure or HEDIS measure in pediatric primary care. So I'm going to walk you through how we do that. And then I'm going to talk about after that, talk about the prevention models and outcomes. Next slide. So I said Geisinger doesn't have a plan, and we don't really have a plan, but Pennsylvania has a nutrition and physical activity plan. And I was fortunate enough to be the principal investigator of that plan way back 20 years ago. And it was published in 2003. So we had funding from the Centers for Disease Control, specifically the Division of Nutrition and Physical Activity. Now it's also called obesity. And so we were one of their first funded states for this type of planning. And then we were one of the first 3 that were funded for implementation of the plan. So again, that happened 20 years ago, and our population focus at that point was children. And we developed a multi-sector plan, kind of like the National Physical Activity Plan. Actually, there's somebody on that plan that contributed to that plan that was also on our planning group in Pennsylvania. So there's a little bit of ties there. But it's a multi-sector plan. And it's still sustained today. So we started implementing the plan 20 years ago, and today that work continues at Penn State Health under Pro Wellness in the Children's Hospital. So that's great. So plans are important. I left the planning, I left that type of activity in 2012. And that is also when I had published this paper in Pediatrics that looked at Pennsylvania, and that's what this map is if you're not familiar with Keystone State. So at the top one is really showing what the population density looks like across the state. So we have 2 large urban centers. In the bottom left is Pittsburgh, and the bottom right is Philadelphia, but everything in the middle is ultra rural or rural. So you can see that that's most of Pennsylvania. And then on the bottom, B is our school-based BMI screening surveillance data for elementary age kids. And this just shows by the rates of overweight, actually obesity in these children. And you can see how that is the darker gray tones, and even like a black tone are the rural parts of Pennsylvania. And the rates are really very high, especially compared to the urban centers, which are much lighter, almost even white in Pittsburgh and in Philadelphia, in the bottom left and right, respectively. So with the physical activity plan, my focus was state and all sectors. And the one that I felt we were having the most trouble with was the healthcare sector. And it seemed to me that we could potentially do better, or could do better in pursuing my career interests in working with the population directly who were experiencing the highest prevalence of overweight and obesity. So next slide. So I moved to Geisinger. So I left those activities and went to Geisinger Health System. So this is a map of Pennsylvania again. And in the royal blue colors, that's Geisinger's core service area. And then the light blue, that's our kind of secondary service area where we still have a lot of clinics in those areas. And in the yellow, that's where we insure lives within the yellow zone. And actually that needs to be updated because we just got the state's Medicaid contract for the whole state. So we'll be expanding our Geisinger Health Plan insurance coverage for Medicaid eligible families throughout the state. So the yellow will encompass the whole state. And our focus as a large integrated health system, focusing on value-based care, is really to help improve all lives, but specifically those who are also insured members, insured lives. So our focus seems like it's ever growing. And also because we're a large integrated health system focusing on value-based care, they definitely care a lot about prevention. So the work that I intended to do made just a lot more sense to kind of do there in an integrated system. Next slide. So when I got to Geisinger, they were thinking about, developing a screening tool for childhood overweight and obesity. And they wanted to know, kind of like what would have the highest impact in terms of pursuing this. Should it just be, a fruit and vegetable screener, or what could there be? And they didn't seem to have a lot of understanding about us already having a state plan and all the work that had been done there. So we kind of talked about that and how to have the largest impact to pay attention to what's going on at the public policy level, looking at the national, state, and local, landscape to see what other work is already happening and where could we go. So that was in 2012. And so my reference point was, okay, let's look at our state plan. We've been trying to make headway in the healthcare sector. And, there is a screening tool and there's some guidance as it relates to preventing childhood obesity. And that's the top right-hand box. So that's the universal screening assessment or universal assessment algorithm from the American Academy of Pediatrics for obesity prevention and treatment. And so at Geisinger in that top right box, identification, they're doing a great job because they've had an electronic health record since 1996. So any place that has an electronic health record is generally in the literature doing a great job of assessing BMI. So that wasn't where we needed to focus our efforts. Then the next kind of working to the right, the next assessing medical risk. Well, that's kind of really the bread and butter of a well child visit or an annual exam. So those things are happening. But what wasn't happening was the behavioral risk or attitude assessments. And I happened to have met Greg Welk, who is the author of the FMPA. I met him in 2009 at a conference, and I was like, "Oh, this is fantastic, and we should really be using this." So I had a sense that this tool could potentially help fill the gaps with regard to assessing behavioral risk and also parent attitude, and that will become more clear as we talk about the way we implement that. And that's for primarily primary prevention of obesity, but those are the same types of behaviors and needing to get a sense of the parent's attitude and the child's attitude that help get them to treatment programs as well. So our intent was for this to be universal at Geisinger in pediatric primary care. So like I said, we looked at guidance in 2007. And while we were implementing this in 2017, 10 years later, the United States Preventive Services Task Force also issued their guidelines. And I want to just emphasize that in healthcare sectors, I know that I'm talking to people who understand this, but you're definitely motivated and attend to, professional society guidelines like the APs and the Universal Services Preventive Task Force recommendations. Those do help to influence practice I know definitely from my experience that it's hard for a plan that's created externally, that's with state level or even local level sometimes, to have, it's hard to have a direct impact in healthcare, but you can align and show how it aligns with other national policies, those professional service organizations, the United States Preventive Services Task Force, and how they all align in order to achieve the goal and to really get momentum going. And I found that to be really helpful. And in the 2017 Preventive Services Task Force recommendation, they also called for a risk assessment. Risk assessment says it should focus on nutrition, physical activity, sedentary behaviors, sleep, but it didn't name an assessment at all. But again, I think FMPA fills the gap here. And there are other tools that probably fill the gap too. I just know FMPA, so I'm talking about that one, and it could potentially extend to things that you're doing locally as well. Next slide. So this is the tool, FMPA. So it is a validated questionnaire. It was developed in collaboration with stakeholders and based on the Academy of Nutrition and Dietetics evidence analysis library. And that's a kind of regular activity that the Academy of Nutrition and Dietetics engages in as needed, as there's a body of evidence to review. They convene experts, review the evidence, create grades, kind of like the Preventive Services Task Force. And that's what informed the development of this tool. So some of the papers that have demonstrated the validity and the predictive utility of the tool are listed there. Essentially what it does is assess parenting practices, child behaviors, and environmental characteristics related to the home that predispose children for becoming obese. So it has a preventive benefit. It can also provide objective outcomes and individual level data, and that helps to engage parents and clinicians and their children in discussions that are behaviorally anchored in a clinical care setting, or people have done this in school and community settings as well. So the tool has 20 questions across 10 different constructs. So you have like family meals, family eating practices, food choices, and a couple of the other things illustrated in blue. I think screen time, physical activity, family activity, sleep behaviors are some of the others. There are 20 questions across those 10 constructs, and it takes about 2.5 minutes for a parent to complete this in our clinical workflow. The FMPA produces a summary score. So a low summary score is associated with a high risk of the child developing obesity, and a high summary score is associated with a low risk for the child developing obesity. So they're inversely related. Next slide. And just to the right point of that slide, I just want to point out the summary score. So I wish there was a BMI cut point that would help us identify children who are most at risk, but there's not. There are percentiles in BMI for age. And similar with the FMPA, there's not a specific cut point. A low score, again, indicates high risk for obesity, and high score indicates low risk for obesity. And that's held true across about, I think at this point, 59 papers. So a lot of evidence kind of demonstrating the same type of inverse relationship. But I don't know exactly the score that is the tipping point. It does have predictive utility. The FMPA summary score helps explain unique variance in child BMI at 1 year follow-up after accounting for baseline BMI, parents' BMI, and some demographic characteristics, particularly low socioeconomic status. And it does seem to have greater benefit or greater associations in determining in the predictive utility for younger versus older children. And the table on the bottom right is from one of my papers, and it just is a sample of kids, you could say, that have with cross-sectional data, and we're looking at their FMPA scores in a group that are 2 to 9, and then it's broken out as ages 2 to 5 and ages 6 to 9. and across different weight classifications. So just to draw your eye to the normal, so in the normal range, it's usually around 65 to 66. And those children have a normal weight category. But then both the underweight and the overweight see a drop, maybe about a point drop. And then the children with obesity, they have about a 2-point drop compared to the normal kids. So it's a very small range in difference. We're doing a lot more work, as are others, to try to understand more about that, and also to understand the subscales within FMPA. So that will be, forthcoming. And then I also just wanted to mention up on the top left-hand corner that we have a website. Please visit that for more information about the different papers that we have and how to utilize the tool. I think that individuals can actually complete the tool online and get the on-screen feedback that the tool produces. Next slide. So this is how we implemented FMPA at Geisinger. So our initial implementation started in 2013. It was initially launched in 6 clinics, and then colleagues in other clinics heard about the tool and they liked it so much that they demanded expansion to their clinics. So then it went to 12 clinics. And it was initially launched in Epic EHR, and there wasn't a patient-reported outcome module in regular Epic, so we had to launch it on screen in DATStat, and then the DATStat data were then fed into Epic EHR, into the child's electronic health record. And we had only started it for children ages 2 to 9 years of age in pediatric and family medicine clinics. And then in the fall of 2020, our system adopted Epic Standard EHR, and that has a patient-reported outcome module. And I think several of the electronic medical record or electronic health record systems that are available on the market today have a patient-reported outcome module. Things like food insecurity are routinely, and other social determinants of health are maybe routinely collected at clinical care. So I'll go to the fall 2020. So the parent authenticates into Epic in the patient portal, and they can do this on their own device or on a clinic iPad or kiosk or in an exam room. They complete as the parent. And then the data are automatically integrated into the child's electronic health record. The parent also gets that on-screen feedback. It says, this is the question, this is your response. These are the recommended practices. And then on the clinical side, what the parent has input shows up in ExpressLane SmartSet as clinical decision support for our providers. And then we also have a progress note that is enhanced with documentation features. And these are things that are possible in Epic, but they are probably also possible in other electronic health record systems. And since fall of 2020, we've expanded to an additional 24 pediatric and family medicine clinics, and we now launch this for children ages 2 to 12 at every annual well child visit. Next slide. Thanks. So the tool is 20 questions, but I just have one of the screenshots on this slide. So the parent completes that. Again, it fits into that behavioral risk and parent attitude from the AAP's Universal Prevention and Treatment Algorithm. So the parent gets immediate feedback and then about what they responded, and are prompted with a question about, do you want to discuss this with your child's physician today or at the well child visit? And the parents either say yes or no. And in our focus group research, when we were designing this, parents said they don't always talk about this with their clinician, and quite frankly, they didn't always want to talk about it with their clinician. It might not have been their practice to have done that. But they still want the information. They wanted to be able to do the screening, get the feedback, and then get educational materials and act on their own to self-direct their learning and any changes. But also, if they did want to talk about it, they wanted to be able to say, these are the priority issues that my family is facing or what I want to talk about. So that's an indicated indicator of their attitude towards change and where they are in wanting to address change. So that information, what the the responses to FMPA plus what the parent wants to talk about are provided to our clinicians as clinical decision support. And then the education materials that we use also come from the Academy of Nutrition and Dietetics in their Kids Eat Right campaign. So there are materials that are updated pretty regularly based on new knowledge in the field and are available in English and Spanish. Next slide. So this is a clip from on the right from our clinicians' clinical decision support. So FMPA results show up as a synopsis report. And the top line in that blue box, our top two lines are the what the parent wants to talk about. That's their agenda. The parent wanted to talk about soda and milk and child's physical activity. And then this is just a snapshot. So the diet, you can see, is the table from FMPA. These are the questions that were asked. And then on the right are the behaviors or the responses that the parent indicated. And to help the provider efficiently use time, the high risk, most obesogenic behaviors are bolded. And that's just to draw their eye to what are the priority concerns that they may want to address. So how the parent or how this happens in clinical care could take a couple of different, paths. Perhaps the clinician engages the parent on the topics they wanted to talk about, soda and milk and child's physical activity. Perhaps they talk about what the clinician sees as being the high-risk behaviors like breakfast and snacking and high use of fast food. Maybe it's both, and maybe it's neither. So those are things that we're exploring now to really understand what actually happens. What we know is that this information is provided in clinical care as clinical decision support, and there is the opportunity for documentation. Next slide. So this is a snapshot from our Smart Set or ExpressLane, which is what we use for all of our well child visits. And I'm just going to draw your attention to the far right panel, and you can see there's like the documentation for HEDIS, the pediatric nutrition counseling and physical activity counseling are at the top. And then down at the bottom are sort of those check boxes for the Kids Eat Right educational materials. And then it's a separate screen, a synopsis report, which is what was displayed on the last screen with the parent agenda and the responses to FMPA. And then they can just automatically populate that into their progress note. Next slide. So how do you track what happens at point of care? It's taken us a long time to get there, and we're evaluating that now, as I'll talk about in the ENCIRCLE study. So these are patient-reported outcome data, and they're stored in EPIC questionnaire response fields now that we have EPIC standard. We're able to differentiate between how the data are entered and where they're collected, and I'll share that on the next screen. We're also able to see and track what the clinician and provider does and which things they're clicking on. So are they using the HEDIS measures, and are they providing the educational materials that are linked with maybe problem behaviors that the parent identified? Next slide. So in terms of implementation, FMPA is only really useful if the parent completes the FMPA, and in the last 6 months, 54% of the parents completed FMPA at their child's well child visit. And on the right, the graph illustrates that we get about 1,500 completions every month in the last 6 months. Most of the parents are completing in the exam room. Part of that is related to COVID. So with mitigation strategies, we try to get the patients roomed within 5 minutes of them arriving to the office. So we have less completion in sort of the waiting room than what we've had previously, and more completions in the exam room. So it doesn't mean that they're necessarily taking away from the clinic, the clinician's time there. It's just that they're not sitting in the exam room, they're sitting in the they're not sitting in the waiting room, they're sitting in the exam room waiting for the clinician to come in. And that's where they are directed to a screen so that they can authenticate into the portal and complete the tool, the FMPA. And parents, about a third of parents say they want to discuss a topic with their child's clinician that day. And the most popular topics are sleep, using food as a reward, and reducing sugar sweetened beverages. Next slide. So at Geisinger, what we've been able to do for the primary care providers is help to engage them in universal prevention to promote healthy lifestyle for their patients and families. Through education about FMPA, and then we also provide quarterly updates and feedback, audits and feedback to the clinicians about the proportion of their patient population that have completed FMPA versus who was offered, so that they can make sure that this becomes part of their routine practice. And that gives us an opportunity to keep talking about nutrition and physical activity and a few more updates along the way to help engage them in learning. So I think they have a better, clear understanding of the complex and interrelated factors for weight gain and obesity. And through those touch points and continuous audit and feedback, they're still using, able to continue to be updated on the best available evidence, and also use that for tailored counseling that's personalized to each child and family. Next slide. So I'm going to transition to our prevention models and outcomes. So I'll talk about the effectiveness of the FMPA screening at 1-year outcomes. Also, what we're starting to learn about multi-year exposure to FMPA and how we're comparing models for prevention and treatment. Next slide. So as it relates to effectiveness, we published this paper in 2019 demonstrating the feasibility of enhancing well-child visits with FMPA and its impact on BMI at 1-year follow-up. At that time, we had observed about 45% of the parents completing FMPA at the period of time that we looked at. And so we've made some improvements, and those improvements are in part, I think, related to how we made changes with in EPIC, from original EPIC to EPIC standard now. And there are just actually, there still are a lot of patient-reported outcome tools that we collect in pediatric care, but there perhaps are less than there were before 2020. So we still are collecting a lot, but not as many. And to help explain where I'm going to go with how we evaluated effectiveness, I'm just going to draw your attention over to the right side of the slide. So we looked at about 10,600 kids who had been seen for a well-child visit in the baseline year. And of those kids, we had kids in 12 practices where they could have been exposed to FMPA. And then we also had about 4,600 kids in other clinics that were matched on similar clinic size and number of providers that we didn't have FMPA. So those were like a control where they were not exposed. And the ones that were exposed, and the 6,000 kids that were exposed, only 2,700 of the parents completed FMPA intervention at the baseline year, where 3,300 did not respond to FMPA. It's thought that on the left-hand side, where the kids were exposed to the FMPA or potentially exposed to FMPA intervention, that that's a better natural observation of looking at the effectiveness of the tool, because those kids had the same providers. They probably lived in, a same geographic region, had similar opportunities for, procuring food and also play and education. So that's probably thought to be a better true comparison of those who completed the intervention and those who didn't respond. And then between those two groups, we showed that completion of FMPA at 1 year was associated with better BMI outcomes in 1-year follow-up. And it's a small change of just in BMI-Z of just negative 0.05, but significantly different. We did not see any difference between the kids who were exposed to FMPA and those who were not exposed to FMPA. And the overall change was that the kids were growing, but the kids that were exposed to FMPA grew at a slower rate than the kids who were not exposed or non-responded to FMPA. And I think the big takeaway here is that Geisinger implemented the screening. It's universal. It's not selective in any way. And once we implemented this, it's sustained. It's low cost. And cost was only upfront. We're not really incurring any additional costs to continue to track and report back to clinicians. It's just part of our routine practice now. And the preventive effect of this low dose, one touch point and sustained intervention that's been sustained for 10 years now almost, is similar to intensive lifestyle interventions. So there's a review in 2015 that looked at 6 RCTs, and the BMI-Z change in those was the same as what we observe from our low dose FMPA screening, and much less costly and intensive. Next slide. So this is preliminary data, and I'm sorry I didn't have a chance to clean this up more, but I'm going to just draw your attention to the far right side in those 3, where there are 3 graphs where there are red bars. And what we're looking at here is the value of repeated FMPA screening in pediatric primary care. And the first bar, the dark blue, is a baseline year where we have a baseline BMI for the child. And then we looked at 1-year follow-up, 2-year follow-up, and 3-year follow-up on those children to see if they had ever completed FMPA. So they're available at every well child visit from 2 to 12, but that doesn't necessarily mean that they're completed. They're probably only half the time. So for the kids that have body mass index that are less than the 85th, so they have a normal BMI, and looking at the difference between like the non-exposed and non-respondent kids versus those with maybe 3 completions of FMPA every year, which is FMPA 4. What we're showing here is that the screening is not having a harmful effect in any way. There's similar growth patterns to children who were not exposed to the intervention at all. So, something to be concerned about with screening is there a potential harmful effect? It doesn't look like there is a potential harmful effect of screening using FMPA. For children with overweight, looking at those with the FMPA 4, so they had the highest dose of FMPA versus those who have been non-exposed, there's not much of a change here. And similarly with the obese children, there's not much of a change there, but I'm going to talk more about obesity in a minute. What that means is that the kids probably need a higher dose intervention than what they're currently getting. They need treatment and maybe coming back for more encounters with primary care. And same with obesity. But looking at that bar in the obese category on the far right with the FMPA 4, so those children with that were the most obese have a lot of repeated FMPAs as well. They have the highest, the BMI, children with the highest BMI-Z. Also, we see a lot of drops there in their BMI-Z moving forward with exposure to FMPA, and the drop is a little bit more steep than it is in the kids who were non-respondent and non-exposed. So overall, that's potentially a good thing. There's a lot more to come there. I did get data last night that I didn't have a chance to incorporate into this slide that was showing that with a 1-point improvement in FMPA score, we see significant decreases. They're small in BMI-Z at 1 year, but at least they're significantly different and decreasing with just 1 exposure to FMPA. Next slide. So talking a little bit more about the models. So we have a study called ENCIRCLE, and it stands for a long title that that you can read. This study is funded through the Patient-Centered Outcomes Research Institute, or PCORI. And what PCORI intends to do is, one of their goals is to compare the effectiveness of interventions and specifically different types of model of care to understand what best works for certain populations. And so that's what we're doing. Next slide. So our broad research question here is, which preventive care model? Is it something that happens in the clinic? Is it engaging the patient or the parent with the clinician, or the patient, clinician, and community? Which one offers the most optimal obesity preventive benefit for high risk preschool age children? So we have 3 models of care at Geisinger that we're testing. So we have the well child visit, which is standard of care. Then we have the well child visit that's enhanced with FMPA. And then we have the FMPA well child visit that has additional interventions that I'll talk about. We call them food care in general. Next slide. And actually go ahead and skip this one. Our arm 2 is what I just described as far as the feasibility and effectiveness. And then arm 3 is the FMPA plus food care. So in here we have the well child visit and then the FMPA, and participants complete a baseline survey. Then they are referred to a health coach, and there are 6 sessions with a health coach. And in the middle of those sessions, there's a grocery store tour. After they finish the 6 months, they have a survey, a post-intervention survey, and then there's a 12-month follow-up survey. The health coach sessions are delivered via telehealth. That was originally designed that way, and that was very fortunate because the study started in March of 2020. So thankfully, we had already been set up for telehealth intervention, or we would have had to quickly adapt. And what we did was adapt Choose Health LA, which is an in-person group-based prevention program that has already demonstrated efficacy in being able to prevent childhood obesity. And it's focused on nutrition and parenting practices. There is some content related to physical activity promotion, but it is primarily nutrition and parenting focused. And then there's a grocery store tour that we have as well. And that one we did have to adapt because that was only in person in March of 2020. And it was adapted by Share Our Strength into a telehealth model. Next slide. So again, just a little bit more about our parenting training program. So there are 6 sessions. Each one of them has addresses a nutrition topic, and each one addresses a parenting topic. And the health coach is employed by Geisinger Wellness. They're not part of the funded study team, and that's intended so that the health system, Geisinger, is able to sustain the intervention delivery post PCORI funding. And the health coach routinely utilizes motivational interviewing as an approach in tandem with her counseling. Next slide. And our grocery store tour focuses on topics like how to buy produce on a budget and compare unit prices, read food labels. And this is intended to help families learn to better utilize and manage their food resources at home. And remember that this is a lower income population, so it's rural, low income in order to participate in the study. And we worked with our community partners in the grocery store chains in Pennsylvania, Giant, Wegmans, and Weis. And they employ nutritionists that were either community facing or employee facing or both. So they were trained on the Share Our Strength Cooking Matters and are utilizing this now in their stores as well as for our patient population. Next slide. So it's just a little bit about the participant flow. So participants are recruited before and after a well child visit. So we use our EHR to screen, and we send them letters and emails and texts, and we also call them to get consent. They complete the questionnaire. If they're not signed up for MyChart, we help them sign up because that helps them get access to FMPA before the well child visit. And then after a well child visit, if they are randomized, if the provider was randomized to arm 3, then they are referred to the wellness coach. And they also get not a cooking tour, but a grocery store tour. They complete the questionnaire at step 5, the post-intervention questionnaire, and then 1-year follow-up. Hopefully they're coming back in 1 year for a well child visit, and we can use that BMI as our primary outcome measure, and then also complete a questionnaire for the study at 1 year follow-up. Next slide. So our recruitment is still in progress. Even this slide from last month is outdated. We have about 1,776 participants as of Monday. We're working to 2,025 participants so that we have adequate power to detect a difference between the groups. And we are comparing arm 1 to arm 2 and arm 1 to arm 3 in terms of comparing the effectiveness of the intervention. Just to draw your eye to the purple boxes. So we started at the clinic. This is a cluster randomized trial. So we started at the clinic level, excluded the clinics in our system that had already been exposed to FMPA. So only clinics that had not been exposed previously would be eligible for the study. And all of the clinics that we reached out to agreed to participate. And then we recruited the primary care providers in those clinics to participate in the study, and about 84% of them agreed to participate. And then the primary care providers are randomized to an intervention arm. They are blinded to know who is in the study. So they don't know if they are in arm 1, none of their participants have FMPA. If they are in arms 2 or 3, all of their patients potentially have the opportunity to complete FMPA. And then our major reason for excluding participants so far that are identified in the EHR is because they are not low income. And it's been a real challenge to recruit during the pandemic. Well child visits and pediatric care have drastically changed. So it's been a wild ride. Next slide. This is our overall model. So when we first conceptualized the study, we thought about randomizing 60 pediatric primary care providers, and now we have randomized 103. And the 3 arms in the green boxes. So the control well child visit, then the 2 interventions. We look at things that potentially can moderate or mediate the effectiveness of the intervention. So community, clinic, and home level factors, as well as primary care providers and parent intentions related to healthy eating and physical activity behaviors and obesity. In terms of like process measures or implementation measures, we're looking at parent FMPA completion. What did they say they wanted to, what they identify as risk and their agenda, and then also looking at PCP, how are they utilizing the FMPA data from the parents. So we haven't had the resources previously to look at this, but now with PCORI's sponsored funding of our research, we've been able to dedicate resources to look at this. And then we're also looking at will the clinics maintain FMPA intervention. And then in terms of outcomes, we're looking always at parenting practices and child behaviors. And then our primary outcome for the study is change in BMI-Z at 1 year follow-up. And we will be looking at other BMI outcomes as well. Next slide. This is a large project, as you can see, and I just want to acknowledge all the wonderful team members that are on here, from all the co-investigators to the study team who work on this every single day. And then we have a steering committee, which is multi-sector boots on the ground team, which has patients as well as clinicians, and 4 postdoc fellows working on the project currently. Next slide. So that's FMPA in how we enhance primary care with FMPA for prevention. Now, just switching to treatment. So this is a project that we just published last month, I think, using family-based telehealth initiative to improve nutrition and physical activity for children with overweight and obesity. So we have 3 interventions here, and all of the children had the opportunity to complete FMPA, but we weren't using FMPA as we weren't using it as an outcome measure or as a requirement to get in the study. We only really use it to look at how do we engage clinicians and family members and children in discussions in primary care. That's our primary purpose for utilizing it. And then we have these 3 interventions that I thought I would just share with you as it relates to what we're doing in treatment, because FMPA was not enough for us to move the needle for children with overweight and obesity. So we're trying to figure out another model that would potentially work for our system. And we tested 3 interventions: a healthy eating intervention, a physical activity intervention, and a hybrid clinical intervention. So the hybrid clinical intervention is similar to, it is a pediatric weight management program. We've had it since 2007 at Geisinger. Hardly anybody comes. So we have about, I think, 400 kids maybe in a year who are referred to the program, and less than 75% of those who start complete the program. So we needed to have some different changes to the way we deliver that program. And I think, as you know, a comprehensive pediatric weight management program is comprehensive, and it may be a lot for a family. So we just wanted to see if we could focus in on healthy eating or physical activity, and if that would potentially be more attractive for families. So we designed these 3 different interventions. And for the sake of time, I'm not going to go through each one of the details, but you can read them on the slide. Next slide. So just a bit about who participated. So this was not a randomized trial. This was a quality improvement project. And we let parents and families pick which one of the interventions they wanted. So it was first come, first serve. We identified the children from our EHR from 3 practices, and we sent recruitment materials to them. And then the parents reached out to us to let us know which one, you find out more information and pick a program if they're interested. Most parents picked the healthy eating intervention. That one filled up the quickest, and we had to stop that one at 40 because that's all the resources that we had. And we still wanted to see if people would pick physical activity in the hybrid clinical program. So after the healthy eating one, the physical activity one, we continued to recruit for that one until we couldn't recruit anymore because our funding had an expiration date. And then the same with the clinical program, the hybrid clinical program, we only had about 6 people choose that program. In terms of BMI, the children were heavier. They all had overweight or obesity. And then just to draw your eye down to the FNPA scores, they were all in like the 60 range. So again, a lower score being associated with a higher body mass index. Next slide. So in terms of a timeline, it keeps creeping up on our work, is that the recruitment, and it was a rolling recruitment, and until we had to stop recruitment. And the intervention started as soon as they were recruited and consented into the project. This was from April 2019 through May of 2020. That's when we enrolled our last participant. Then they had the 6-month intervention and completed a post evaluation. And then they also had a 1-year follow-up. So a lot of our follow-up data were collected during the pandemic and the shutdown. The quick story is that we had a lot of desirable changes in terms of behavior for healthy eating. And we used the physical activity questionnaire for older children to measure physical activity change in behavior, and we did not observe any differences from baseline to post-intervention or baseline to 1-year follow-up, although we did across multiple nutrition measures. So we had talked to some parents, and it's just one of the quotes from the paper we published about the challenges that the pandemic presented for children for physical activity. I think at home, our focus was on family meals and preparing meals at home, and that was probably easier to accomplish.
It's not just me, is it?
During the pandemic when people were at home during the pandemic.
Lisa, you're freezing on us. This may take us a couple of minutes to get her back. The good news is I do have the slides. I can just keep going through the presentation.
Next slide.
Lisa, you're cutting in and out on us. Give us just a second. The good news is she's right at the end of her presentation, but I sure hope we can get her back here for a great conversation. This has been really valuable information and a unique experience, an interesting experience. Let's see. Veronica and Katie, if you'll just monitor for when she's able to come back in. It looks like Dr. Hampel and Dr. LaRush, let's see, yeah, might be on the call, along with Dr. Dickmeyer, who have some great experiences to share with us as well. Lisa, are you back?
Hey, I'm sorry. There's a storm moving in. I'm
Oh,
sorry.
perfect timing.
Thank you. So we did not, we didn't see any significant differences between the groups in terms of BMI-Z. They trended in, the BMI trended in the right direction in favor of the intervention, but no significant differences. Next slide. And then I just wanted to end with sort of this slide that I think emphasizes the direction that we're trying to move in Geisinger, and really the intervention for Encircle and some of the other work that I've been talking about here. But we're trying to follow this integrated framework for the prevention and treatment of obesity and other complex public health concerns by thinking about how we can engage the parent and the child with clinical care delivery and community systems, so that we're not working in a vacuum, but working to understand the community context of where people live, and maybe, you know, the services that they're receiving in the community that are aligned or affiliated. And that's kind of what we're trying to do with Encircle and that food care arm, working with our wellness partners who provide a lot of services for a Medicaid eligible population. And then also with our grocery stores, who obviously are there to help, you know, provide access, you know, to available food. So I think by integrating and thinking about how we can work together, this is really kind of the heart of the multi-sector approach. And we've demonstrated that this is feasible, not with FMPA, but with a different tool we have for early, for infants in from 0 to age 2. In connecting, that's a tool that we have called Early Healthy Lifestyles. So that's our FMPA for infants and toddlers. And we connected that with pediatric clinical care and WIC care, because most children at birth in Pennsylvania are participating in the WIC program. And we routinely coordinate care and share data between what the parent says, kind of on the AHL tool or the FMPA tool with the clinician, sort of that synopsis display that you saw, and what's going on with WIC. And WIC can boost what the clinician says, provide data back, and continue to share that feedback loop. And that also has been really helpful and has resulted in desirable changes in BMI-Z. So we're excited to continue to move forward with that type of work. So it's something to think about as we move forward. And I'm happy to take any questions if we have time for that.
Yes, we definitely have time for that. Thank you so much. It was a great presentation. And I'll just open it up to the group. So I'll stop sharing my screen so I can see the chat. But if anybody has the question, I'll go ahead and open it up to you all first.
I saw one question in the chat. The question was, how do you account for the fact that parents who are concerned about and motivated to change are more likely to agree to do the FNPA?
just thankful that they are concerned and that they complete it. Yeah.
And I had a question, and maybe you did this at the very beginning of the presentation that I missed, but what percentage of the patients in this study or in the FNPA are Medicaid patients, and what's the payer mix for private practice? I was just interested if you guys saw a difference in completion rates for patients with Medicaid or language barriers versus private practice or private insurance.
Yeah. Overall, it depends on by age. So the younger the patient population that we're looking at, the more likely is that they are going to be Medicaid covered. And that is particularly true because it will increase because Geisinger just got the statewide Medicaid contract. So that's going to increase. And then to your point with, is there a difference in completion rates by SES, for example? Yeah, I think there is. We haven't published those findings as it relates to FNPA yet, but we're working on it. And we just are about to hit a publication with the other tool, EHL, that does discuss what looks like the parents that have ever had Medicaid or the child has ever had Medicaid have lower completion rates. And it looks like they don't have the same access to have the data collected at the point of care as persons without who are insured differently or privately.
Yeah, that's kind of what I was thinking, but it would be interesting to see those numbers.
A lot more work needs to be done there, Jody. Yeah, thanks.
Lisa, thank you. This was so great and good to hear this again. Can you remind me, when you say FNPA completion, is it only the parent completing the questions, or is it also that plus the provider doing some counseling?
It's only the parent completing the questionnaire. It's not the clinician doing counseling. So that latter part, we're starting to evaluate with the resources that we have through the Encircle trial. We didn't have the ability to do that previously. And I think also in 2020, when we switched to Epic standard EHR with more of the, SDEs, those data elements, we were able to better detect the actions that the clinicians take.
I also wondered if you had any thoughts on, initially you shared that about only a third of parents wanted to discuss an FNPA topic, knowing that, there's a lot of good topics in there and you wish that more parents would want to discuss. Do you have any thoughts about why that might be, that, that 2/3 of parents didn't respond that they wanted to talk with their provider about an FNPA topic?
Yeah, I don't know, Sarah. I think it might be, I would go to what they told us in the formative stage, where they just weren't always used to talking about this with their provider, which is weird that, I was surprised by the fact that they didn't necessarily think that they would go to their child's provider to talk about healthy eating and physical activity, but they kind of thought they would talk about gun safety and bicycle safety and other things, but not necessarily obesity prevention. And I think it just underscores the need to help families realize that there's help available to them and that they don't need to struggle on their own. They can reach out to the clinician and the health system to find some resources to support them in trying to make changes. And that, that continues in the adult space too, where people they try a lot of things on their own before they ever talk to their clinician about a change.
And do you find, so building on that just a little bit, do you find that the providers are coming at it from an obesity prevention or treatment standpoint, or are they coming at it from a healthy lifestyles and this is good for everyone, or do you know?
It's the latter. They definitely dance around. They don't talk about obesity prevention. They talk about, healthy eating, physical activity, getting adequate sleep, and healthy lifestyles more than they talk about obesity prevention. And actually, is it related to that last study I talked about with the treatment program? We were recruiting most of the participants from our study team. It was possible for the clinicians to refer families to our study team for the intervention. And I think we enrolled like 77 total families. We had that number wrong, but only 3 of them were referred. from primary care practice. And that's even, I mean, that's despite we have long relationships with these clinicians. It just, they're not talking about it in practice as far as obesity prevention and treatment. They talk about as healthy lifestyles.
Hi, Lisa. Great presentation. So much excellent data. And apologies if you presented on it and I missed it because I was thinking about something else. But do you know how long it typically takes to fill out the entire survey?
Yeah, 2.5 minutes.
2.5. You can go through all of those things in 2.5 minutes.
Yeah,
Wow, that's great.
yeah.
And do you, how much communication did you or did anyone have with the care teams in terms of how they can present the survey, how they can respond when a parent has a question about a question? How much technical assistance do you have to provide either initially or like on an ongoing basis, simply to like administer the thing?
Yeah, great question. So our system is set up that if the patient-reported outcome measures, regardless of what they are, so if it's ages and stages, or if it's FNPA or whatever it is, it's queued up for that child at a well-child visit. The front desk staff see this as an open care gap when they're checking the patient in, and they see that that's something that hasn't been completed. And that's when they are prompted to ask the parent, do you want to complete this on your own device, or do you want an iPad? You want to go to the kiosk? And that happens less now than it happened before the pandemic, but now they're mostly taken to the exam room by a patient access representative, and I know they're called different things in different systems. And then they kind of, weigh and measure, take vitals, and then they say, would you come over here now and complete these questions on the screen? And they typically leave the parent alone to complete those and maybe come back in, make sure they're done or whatever before the clinician comes in, but they're not usually there to answer a lot of questions. And I appreciate that that's a different way than the way that I think you guys are collecting other data, the 1, 2, 3, 4, 5 data in care now. So we're not doing it by interview. It's really the parent's self-assessment, and they're not really asking a lot of questions. I don't think we're collecting a lot of data from parents who are not English speaking as well.
Great. So like if they would have a question, if they're like, I don't know how much screen time they get or something like that, they just do their best or skip it or something like that. Is that probably?
Yeah.
Okay, great. Final question. Do you have like built-in clinical decision-making tools in your electronic health record? So, like, oh, flag, these are some flagged items, here's discussion points, or here's resources or something?
Yeah, well, we have best practice alerts. So there are those. They're pretty much ignored universally at Geisinger. I think we're trying to not have any more of those at all because they're just not useful anymore for our population, our clinicians. And then we have some different talking points, not with FNPA, but we do with the other tool I mentioned, the Early Healthy Lifestyles tool. There are talking points about, promotion of breastfeeding, promotion of like introduction of solids, just to make sure that they know that. And then to get back to your other question that you had for like, what kind of training did we do? So when we launched this initially, we went to, and I think we went to all of the regular routine standard meetings that the pediatric service line had as far as a department. And then also at the local clinic level. So we went, virtually, and then we also went in person and talked about FNPA. There's something called FNPA Fast Facts, which is just this thing that, just a PDF really that hangs at a bulletin board, if you will. in the charting room that clinicians and other staff can look at about what's the workflow look like for FNPA and how do you talk about this and document on it. So that's always there. We boost that education, like with study things and any changes. So when we switch from Epic regular to Epic standard, we talked about how that was changing and what that meant for FNPA. When we got the Encircle funding, we talked about this is an opportunity to talk about boosting, nutrition, physical activity knowledge, talking more and more about sleep all the time, and talking a lot more too about sedentary activity and behaviors and how to reduce those. And then the audit and feedback reports are other ways that we're able to continually engage on a quarterly basis. So that usually is an electronic communication with the operations manager who disseminates that to the clinicians and staff. But right now, we happen to be going to the pediatric practices and providing that audit and feedback report, giving them, just a reminder of this is the fast facts, this is a tool, and asking them what questions they have and trying to understand how workflow has changed with the pandemic, because there's been so much turnover in the patient access representatives that they haven't been cued in as much to understanding that they need to collect data and address open care gaps. So we're focused a lot more on that right now. And I felt like the only way that we were getting deep knowledge about that was to go to the clinics directly and investing, time and resources to go there and see it and hear it firsthand.
Great, that's super helpful. I guess I lied and I have one more question. Do you have, you guys have been using the FNPA for a while. Do you experience a lot of, I don't know if competition is the right word, but competing interests for the precious time that is available before a physician walks into a room, whether it's, oh, we need to pick only a couple things, and right now it's, social determinants of health or something else like that?
Yeah, it's a great question. I think when we moved from regular Epic to Epic Standard, there was a lot of discussion about there are too many things right now. We're collecting too many questionnaires. Somebody came in with a specific interest with the Bears sleep questionnaire, and now they're not even here anymore. Nobody's using the data. Let's clean this up. So fortunately, had a really strong network in the leadership team to be able to say, look, FNPA is important. And it wasn't a hard sell. Our clinicians love the tool. And in the Encircle, when I was talking about, we randomized some providers not to get it, they're mad that they don't have it. And they constantly try to work around to get it. And then thankfully our Epic team lets me know, hey, Dr. So-and-so is asking for this. Can I turn it on? I'm like, no, they're in the control arm. So it's great to have that type of network. But yeah, I think you have to be constantly present on multiple levels, so that you're understanding and saying, hey, no, this is really helpful. I was in 12 clinics, and all the clinicians said, don't take this away. This is really helpful. Help the PAR staff to know that they need to collect the data and make sure that we're getting this, particularly on these kids. They still may not talk about it in that office visit if they only have 20 minutes and they need to talk about gun safety. That may be what it is, but having that data there, and if parents can act on it independent of a discussion with their clinician, that's great.
Awesome. Great. Thank you.
Mm-hmm. Thanks.
So one question sort of related to this is staff. So are your staff that are providing the support to the clinics to identify the challenges, and make sure the new staff that are coming on are trained, are they full-time employees paid by the system, or are they grant funded
Yeah,
staff?
they're grant funded.
Yeah.
I'm fortunate to have a big team. Yeah. And a lot of funding. I'm very fortunate to have a lot of funding.
And so if you didn't have that support, what do you think would happen to the project?
It would be really hard. Yeah, it was, when I wrote the plan, the state plan, I only had 2 clinicians that were part of the state plan, my team. And I don't know why, but they were Geisinger clinicians.
Hmm.
It's so weird. I was so fortunate to have had that. And then when
Yeah.
I got to Geisinger a couple of years later, the one clinician was the vice chairman of pediatrics. So I had so much political support.
Yeah.
And that's really important.
Yeah, yeah, I
Mhm.
agree. There is a question that came in through the chat from Jordan Carlson, and I think it's, what is the hospital wellness department that employs the health coaches? So what kind of department or group is it? Is it employee wellness? Is it
It's
primary care?
It's employee wellness, and they are in part funded by our health plan. So our health, and it's a nonprofit health plan. So as part of the the Affordable Care Act, their plan, the health plan needs to give back part of their earnings for community benefit. And their community benefit that they give back to our large community is in the terms of wellness, and they'll offer programs for free, like the diabetes prevention program, for example, diabetes self-management program for those with uncontrolled diabetes. And then they are also staffing the health coaches that are delivering the Encircle intervention.
I have a question real quick. Do you know if your providers are able to get any billing or reimbursement for talking about the physical activity or the lifestyle habits?
I don't think they're not directly getting the reimbursement. So our physicians are all employed by the health system directly. And then they get higher returns, right, if they're documenting the quality measures, but that goes to the system, not them directly.
It is great that the system is billing successfully for that counseling.
Mhm. Yeah, that was a major carrot that we started with in 2013 when we started planning.
So is
Yeah,
that
Sarah,
tied
we
to,
need to figure some of this out, don't we?
yeah, is that tied to the HEDIS measures, or is that tied specifically to, nutrition or physical activity counseling outside of making sure you're meeting those requirements?
Just the HEDIS. Yeah,
Okay, so it's not additional billing or reimbursement. It's ensuring you get that reimbursement.
exactly.
Okay, so it's a little bit different than what we're sort of thinking about here. So before, I know we're, I could keep asking you questions, Lisa, but I want to get to this next phase, which is actually talking with the healthcare sector team and think about how this might apply to the strategies for the healthcare sector work group. So with that, before we make this transition, I want to say thank you to Dr. Lisa Bailey Davis for joining us in an outstanding presentation. So you're all welcome to join me in giving her a standing ovation.
Oh, you're so kind. Thank you. It's my pleasure.
And I'll invite you to continue to stay on with us for the rest of the conversation if you'd like.
Sure, I'm happy to do so. Thank you.
Oh,
Shannon.
great.
Thanks, everyone.
Okay, well, I know we'd all probably like to take a short break. We're going to have a little physical activity break that Katie, I think, is going to bring up for us. You're welcome to join that. You're welcome to do whatever else it is that you need to do at this time. You're welcome to leave your screen on, or if you need to turn it off, that's okay as well. We're going to take about 5 minutes to stretch.
So happy to be a part of the Junior League of Kansas City, Missouri's 4th annual C3KC event. Children's Mercy and the Junior League have been partners and collaborators since 1950, starting when the Junior League members sewed diapers and surgical dressings for what would later become Children's Mercy. Since then, the League has raised money to fund the Cardiac Care Center and the volunteer coordinator and parent consultant positions, plus donated thousands of volunteer hours across many departments. What a wonderful community collaboration it has been, and we look forward to many more years working together. Hello everyone, my name is Bryce from the Center for Children's Healthy Lifestyles and Nutrition at Children's Mercy, Kansas City, where we work to promote children's healthy lifestyles and physical activity in the Kansas City region. Today we're going to do some exercises and some stretches for you guys. Most of these can be done while you're sitting or while you're standing, so let's get right into it. The first one we're going to do, we're going to lock our fingers and we're going to stretch all the way up to the ceiling. Try to touch the stars, get on your tiptoes a little bit, and then we're going to bring our arms down right behind our neck. Bring our elbows in. And let's rock back and forth. Right, left, right, left. Good job. All right, back up to the starting position. And now let's get some head circles in. You might hear some cracks, that's okay. Good, and now let's get our whole body involved and let's shake things out a little bit. Get ready for some of these main stretches. Awesome. Let's bring our arms up and we're gonna do some core twists. We wanna get a little bit of a wider stance. We're gonna go left, right. Nice, rock solid. Perfect. All right, and all this can be done in a seated position as well. It would be this type of variation. And we're gonna move on to the next drill. So we're gonna do some knee pulls. We'll start with our right. You wanna grab right below the knee, pull up towards our chest, hold it for about 5 seconds. It's okay if you lose your balance, find something next to you, find a table or a chair. You can hold your balance just like that. If you're seated, you can do this variation. Back to our right leg. Good job. All right, and then we're gonna transition to some toe touches. Touch our right toe. Try to hold that for about 5 seconds. If you can't touch your toe, that's totally fine. Just touch somewhere in your shin. See how far you can get down. 3, 2, 1. Awesome. If we're standing, it's gonna look like this. See how far you can get down that shin. Try to touch your toes. Awesome. Nice and controlled. We can focus on our breathing in through our nose, out through our mouth. All right, we'll do a quick hamstring stretch now. Our right leg, we're gonna reach down, grab that foot, pull up towards our butt. Good, hold for about 5 seconds. Awesome, left side. 2, 1, good job. If you're in the seated position, it looks about like this. Get a good stretch in. If you're not able to grab your foot, that's okay. The variation would just be leaning back and trying to reach down with your hand as far as you can. Good, all right, on to the next one. We're gonna get a glute stretch in now. When we're sitting all day at home, this is a good stretch to make sure that things are activated. Our big muscles in our body are activated while we're sitting down. So we're gonna bring our right leg up, sit our ankle on our leg. You can lean forward for a better stretch, hold it, and then we can lift up on that leg just slightly. Good, we'll go to the other leg. If you're standing up, it looks something like this. Good, lift it up a little. Okay, and our last one, let's connect our fingers again. Let's reach to the stars. And let's slowly flow down into a forward fold. Grab those elbows. We can sway to the left and the right, left, right, sitting down, looks like this. Left, right, and good. There we go, guys. Thanks for joining me. These are all exercises you can do at home. And as we're sitting at home, if you're working from home or in a seated position throughout the day, these are fantastic ways to get moving in an easily accessible way. Thanks.
It's good to see Bryce again. Thanks for finding that, Katie. We forgot to do variations though for people wearing skirts. So that will be the next modification.
We'll keep that in mind.
Yeah. Shelly, you want me to start with this next group? Think everyone's back?
Let's give it a quick, for those who have their screens on, I'm gonna say yes, they're back.
Okay, perfect. So we are going to go back into the updates on our implementation groups that we have for our KCPA plan. I guess I could start with Just Walk, Shelly, unless you want to start with it. Okay, so we've done 5 Just Walks since starting in April. We have our next one coming up in September. We implemented that for the second Saturday of each month from 9 to 10 at Pearson Park in Wyandotte County, and we targeted Wyandotte County just because they have some of the highest rates of obesity in Kansas counties. And then we also had some connection to the Turner School District. So that's another reason we chose that park. We have started to get some more interest. Veronica has been really amazing at going out and trying to recruit and advocate for us. And we actually have a La Casa meeting tomorrow that we're also gonna recruit or give some more information during that talk. We have a pretty good amount of volunteers. We have general volunteers, and then we have a healthcare lead who does the topic every walk. Then we also have volunteers to help with the kids group activities. I know that several of you have gotten good workouts with the kids, the kids running around the tennis courts. So we're really just working on continuing to get more participation from hopefully families around the Turner School District, and then continue to keep up our volunteer profiles. Did that pretty much cover it, Shelley? Okay. All right, so for our, I think I saw Jay on the talk here. Next one is the curriculum exercises medicine subgroup. If you want to give an update on that.
Yeah, hey, this is Jay, everybody. Hope you can hear me. I have a meeting set up just to go over some curriculum stuff for the clinical practices medicine, practice of medicine, sorry, group that is kind of going to be our initial foray into the exercise medicine. Try to get a date where we could do a lecture with that, just going over something simple like exercise prescriptions. So I'm going to be able to talk to them, see if they can kind of wedge us in their second semester for the med students, and then we'll go from there. See if they got time, and then see if we can make it something that just keeps growing every year, and spend some more time in the curriculum, also with the PA students and all the other healthcare professional students eventually.
Okay, great, thank you. And then Dave, I saw you on the call too to talk about billing and reimbursement.
Yeah, billing and reimbursement, still kind of a challenge. And hearing the talk and seeing those health coaches are paid through grants mostly helps us kind of frame that a little bit more. So where we are now is we applied for, I'm trying to think of where to start. So we put in a thing for the Spark Bash initiative thing to do a remote exercise prescription, to develop a remote exercise prescription program that uses an app-based prescription exercise delivery model, and hopefully leverage the remote patient monitoring codes, which we think should allow exercise physiologists and to be reimbursed for this. And through this, we received a little bit of seed funding. It's not a ton, it's like $2,500. But since then, I've had some meetings with Mark Clements, who this overlaps with a lot of the stuff he's doing in endocrine, and a lot of the conversations he's having with our billing folks and with others about how we can leverage these codes to address some of these things. That the REPS program is kind of riding on those coattails in a lot of ways. But while that's happening, we're doing some other simultaneous work trying to put together what modules will be available through the REPS program, and kind of identifying what kind of behavioral aspects are needed that should be included in the REPS program to help with adherence. So, so our plan for the billing and reimbursement is to try to go around the traditional billing and reimbursement methods of codes in clinics and try to find a backdoor into that allows to bill.
Okay, great, thanks. Does anyone have any questions on those 3 implementation groups?
Sorry, I saw one of the chats. Geisinger Health coaches are paid by Geisinger Health Plan Insurance as part of the community benefits at the ACI, not for nonprofit insurers. So it's funded by the insurance. Just to clarify, that they're funded by the insurance plan, but not by the hospital. Is that correct?
Yes.
Okay.
Yeah, one organization, and we have the clinical care as one stream and the insurance as another stream.
Got it. Okay. Yeah, I mean, I don't know. Is that a method? Do we try to get insurance companies to sponsor health coaches? I feel like that's a whole different working group.
Yeah, you go for that, Dave. Sure, you have plenty of time. But certainly if
You know, but-
anyone on this call is interested in that, that would definitely be something that we could move forward with.
Well, and Dave, I think as you get your project going, and if you have outcomes that would be valuable for insurance companies, like chronic disease risk reduction or improvement in cardiorespiratory fitness or something that's meaningful that reduces their overall expenses, I think we would then have a leg to stand on in terms of asking for that type of support for a bigger research project related to that.
Yeah, I totally agree that the biggest, I mean, the data on like the benefits of this, of exercise and clinical exercise prescription is out there. It's just about how to get reimbursed, like how does the money flow and who it should flow through? Because currently the way the models are built, that they flow through the physician, which makes the physician be the one who does primarily all of the counseling and exercise prescription and all the time that is required for that. Which disincentivizes people to do it. So, yeah.
Yeah.
All right, well, since we don't have to move into breakout rooms, we'll just stay in this screen together. We had a few follow-up questions that we can all chat about, or if you guys have your own questions, please bring those up here as well. So we wanted to start with, what is your organization currently doing to ensure that children are physically active?
I think for most of us, we know what that is, but for a few of us that I can see, if you don't work at Children's Mercy, is there anything that your organizations are doing that helps provide opportunities for kids to be physically active?
And maybe even Sarah and Helena could talk about this, what they do in the Fit Clinic. Maybe give some ideas to us as well.
Looks like Sarah may have had to drop off. I don't see her on anymore.
Yeah, I'm gonna have to drop here soon too. I didn't realize it was 2 hours. What do? We talk to them individually and see what we can come up with, and then if we can't figure something out, we beg Dave. If we're lucky enough to be in that bar.
What is it that, so in Lisa's presentation, she shared that the most popular topics for families related to the completion of the FNPA were sleep, food as reward, and sugar sweetened beverages. Physical activity wasn't included in there at all. Lisa, do you have any insights for us on why that might be?
I'm sorry, I had to answer my son's question. Can you repeat that, Shelley?
Yeah, no problem. The most popular topics that you reported from completers of the FNPA were sleep, food as a reward, and sugar sweetened beverages. None of that is related to physical activity. So I didn't know if you had anything you can share with us in terms of why you think activity or even screen time is not really chosen.
Yeah. Well, that was, let me see, when did we look at that? We looked at that prior to the pandemic, so perhaps it would change now if we took a look at it. I do hear the clinicians saying, a lot of them even talking about their own personal practices, like that they would use food as a reward. So I think that's kind of a shocking thing, like that people don't think about, like not using M&Ms to incentivize child behavior. So I think that's a learning opportunity for just everybody. And sugar sweetened beverages, they're definitely pervasive. I don't know why they're not thinking about talking about physical activity and why it was so hard to think about improving, like recruiting people when we were offering them a free Y visit or free Y membership for the family, and they still were not saying that that's what they wanted. And then we started to get creative, like, all right, well, if the child wants a new mountain bike, we'll buy a new mountain bike, or, some other thing. So I just think that needs a lot more work and touch point with community organizations so that it looks like it's well connected to health and it's like socially supported as a behavior that should be practiced. And I think you guys have a goal about related to that, the healthcare in the healthcare sector, that providers would be role models for physical activity. I think that type of thing is really helpful. It's like your walk with the doc program.
There's a little bit of research on that I've read on providers being apprehensive to discuss exercise and physical activity, and some of the qualitative research has come out that they just really don't feel comfortable at all talking about it. They just don't. I think the outcome was they don't feel like they've been trained adequately to discuss exercise and physical activity with patients. Did you have any data that supports that, or anything different, or did you not maybe look at that part of it?
I agree. That's what I hear too. It's a lack of training. I mean, I hear that all the time. And then training and time that they have, not feeling efficacious in what they're doing. So I just think there's a lot more opportunity. And I think one of the challenges that we face too at Geisinger in promoting physical activity is that you can refer to a dietitian for nutrition counseling about healthy eating, but there aren't as many professionals. There's some, but very few to refer to for increasing physical activity.
And I think that holds true, right? You know how hard it is for Jay to get the exercise medicine into the curriculum, right? Like it's not in the curriculum. We don't talk about it. And even for my patients, I usually bring up like after talking, here's the 3 things we could talk that you guys could change. What's the easiest for you to change? And it's usually not the physical activity that they pick. And sometimes I feel like it just seems very overwhelming for them. They think they should be doing like 30 minutes or 60 minutes a day, which obviously is the recommendation. But like, I usually talk to them about like, let's do 5 minutes. Like, let's pause your games and do 5 minutes of exercise where you're feeling your heartbeat. Like, go. And I feel like that maybe feels a little less overwhelming for them. So, and I talk about easy things to do. Again, like if you have to go to a gym, if you have to buy exercise equipment, they're not likely to do that. But if they could do jumping jacks or sit-ups or push-ups or do a dance party in their house and they don't have to go anywhere, I think that's really helpful. I definitely saw during the pandemic, physical activity was way down in our families. And so trying to figure out ways for them to be creative at home, I think is what I've been trying to work on.
So for those of you who are clinicians and seeing this a little bit more than me, I find it really interesting that people don't feel qualified or trained. To me, that means they have an expectation of, I've got to give a prescription. Like I've got to tell them to, go exercise 3 to 5 days a week, and it's got to be at a moderate to vigorous rate. And here's how you know what that is, versus simply get outside and play, go to the playground, ride your bike, or those really basic things that are actually being active. They might not rise to the level of, intensity, but are you all seeing that? I mean, and that applies more to a pediatric population, but an adult population, simply asking them to walk would be reasonable. What are you all experiencing from that perspective?
I typically redefine exercise for them right at the get-go. Because I try to wipe out those kind of stigmas what a physical activity is and what exercise is. Because sometimes people think exercise is this really vigorous, painful, and difficult thing. And then they'll say physical activity is, oh, I walk, my room is in the basement, I have to go upstairs, so I'm getting all this physical activity. It's like, yeah, that doesn't really count. So I usually redefine those things for them. And then once I redefine it, then we start the recall based on those definitions. And my definition of exercise is any physical activity that's on purpose. So it's very, very vague in general.
Yeah. Yeah, I think that is where a lot of the fear of giving the advice comes from. I think on the physician level is, oh, I'm not an expert on this, I shouldn't give advice, when it is really just making it as simple as you can for the patients, pointing out to them any is good, more is better, get your heart pumping a little bit. I mean, just something that simple. But that's that's part of what we want to teach the students.
And
eventually.
so Jay, it makes me think a little bit about something we've talked about just briefly in the past, and it's really connecting to the school sector. And it's really around teachers, but in professional development for teachers, looking at the difference between physical activity, physical education, and then the other components that go along with being active, physical literacy, and some of those pieces. So that sector of the PA plan is interested in professional development. We've been focusing on curriculum and embedding it into health professional schools. But is there a benefit to looking at this part a little bit differently and thinking about professional development for healthcare professionals broadly? So it would be targeting like family practice, pediatricians, internists, I don't know, people that would be having these conversations or should be having these conversations regularly with their patients.
I mean, I think that's I think that's a great thing to do. Dave and I are actually doing CAPS later this month, specifically on this topic. I'm kind of giving a little overview of the regional report card, and then Dave's going to talk about some actual like physical activity guidance and tips and way to get your patients more active. So whenever we can stick that in to any curriculum or any lectures to groups, and that is really what the exercise medicine curriculum is about. There's stuff for providers, there's stuff for the layperson, just for you can even take it to, like, I way early on when I was at Children's, a couple different corporations around town asked somebody to come talk, and so I did an exercise medicine talk to just like a lunch crowd at Freight Quote or something like that. So I mean, I think there's lots of ways to get it in there. I think doing the professional development like you and I had talked, Shelley, with some teachers, PE teachers, coaches, things like that. I know that a lot of our physical therapists really want to get engaged with that. It's just finding the right group to go after. I think at the school level is hard because not all the schools have the same time off. Do you do a conference? Do you do just some recorded videos? Those are all things I think we need to figure out. But anybody who can get a little more education on what physical activity is and how to get people just moving an extra 5, 10, 20 minutes a day is a great place to start.
Yeah. And Lisa, there's one other question I wanted to ask you, semi-related to this, but does Geisinger connect back to their community? So going back to the plan piece that you were involved in, does the system go back and support or promote physical activity opportunities in the community, or how to build capacity for that? Do they do it related to anything else?
So I would say that there are several strategies that have emerged, over the last 20 years that they've done. And we have, I don't know if I mentioned this well, but we have 7 or 8 hospitals right now. So a lot of different campuses. And one of them has been more closely tied to a community-wide physical activity intervention called the Wyoming Valley Wellness Trail. So that's been a more massive, consistent physical activity intervention in that region. But we have a large region, so that's not really meaningful if you live 3 or 4 hours away.
Yeah.
And then as it relates to kids and promotion of physical activity, we have this tool that we created. It's an app. It's called Pediatricians Prescribing Play. It was initially funded by HRSA as like this grand challenge to get kids to be more physically active. So there were a couple of different places funded, and I think we made it to the final 2, but ultimately lost out to Temple University, who had a more innovative design, I guess. But the idea was just that the clinicians, they loved it. They loved being able to say to parents, here's a prescription to play. And it was simple. It was related to use this app and collect farm animals or stars in planets in the galaxy. They're just 2 different ways to do it. And you get points by, doing stretching or doing, a little dance video, and kids could video themselves and share it with others or share it with their family members, whatever, and get points. And they loved it. We're having a hard time getting that, sustaining that intervention. But I think doing things like that, like you're talking about, just simple ideas about how to engage people in conversations in the clinical office to show that physical activity is important. It's not exercise. It's something simple and it can be fun, is really valuable.
Yeah.
Yeah, that's what it is. Thanks, Dave. Our medical students helped us with that, and they were a big help. I think that publication that Dave linked there is related to that.
Yeah, I think, based on that too, even talking to patients about like, do you have video games that are interactive? Like that might capture some attention. I just had one patient today who's like, okay, I'll do those like virtual reality goggles and kind of move around on that. So I guess anything to get them moving and dancing is more interesting than heading to a gym for them.
And I think it's also important that whenever we talk about physical activity, we don't just address it as an obesity issue or a overweight issue, that it's more of a lifetime health, all the different benefits of physical activity should always be kind of hinted at least. Because I think some people might get away with thinking, well, I'm not obese, so I don't have to worry about it. And then they're really still not healthy. So
yeah, I talk to it a lot with my patients who come in for like mental health screenings. We talk about that as part of their kind of treatment plan too. And even if like headaches, that headachereliefguide.com, physical activity is one of their peers there too, or the pillars, sorry. So I feel like it's so important across multiple sectors, just like you're saying, Jay.
Yeah. And just a simple act of going outside can help from a mental health standpoint. It is, Dave, does that count as doing physical activity on purpose? I went outside.
So I define, when I do this it depends on the patient population I'm working with. But typically I say exercise. I'm trying to destigmatize the word exercise because exercise is scary. So I still use the word exercise quite a bit. I just tell them what it is. Exercise is anything on purpose. And then I say any movement that's on purpose. And I say any effective exercise. So exercise that's good for your health has to be at least 10 continuous minutes and has to be, I use a 0 through 10 perceived exertion scale, an RPE scale. And I say at least to be at least a 4 out of 10 intensity. So where you're breathing just a little bit harder than normal, but you're not breathing so hard that you're like, you can't talk, but you're a little breathy. So, if they are going outside on purpose to move, then I count that as exercise, but then we go into the level of like, well, is that effective exercise or not? And then that gives you the leverage to go like, why don't you try doing 5 more minutes? So it gets 10 minutes. So you know it's doing something for your body. Or you start doing can you do it hard enough that you start breathing just a little bit heavy? And then once you get to the point where it's 10 minutes, breathing a little heavy and intentional, then you're in a good spot.
Yeah, that's really helpful, Dave. Does anyone have anything outside the Children's Mercy organization that they want to talk about that they're working on? And also, if anyone's on this call who wants to help with any of those implementation groups, you can just either put your name in the chat or you can contact Shelly or myself and we can get you added to those as well. Shelly, should we move on to the wrap up?
Yeah, I think so. We're sort of at the end of our time and there are a few other things that we'll share with group.
Okay. All right, so we did have some wrap up and reminders for upcoming meetings. Oh, what's this?
That-
You're just okay. These are our sectors for our KCPA plan, and different presenters that are coming up with the dates and times. If you're interested in any of those, you can get signed up on the KCPA plan website and get a Eventbrite invite, just like you did for today's talk. For our next sector meeting dates, the ones that we have scheduled so far. Oh, gosh, Shelly, you're moving ahead of me. This is we can go back to the summit. That's okay.
My apologies, that was me.
No, it's okay, Katie.
That's my next slide. I wasn't sure where you were.
Yeah, you can go ahead and go to the next one.
Okay.
So this is our KCPA Summit. It's going to be from 9 a.m. to noon on September 29th. Again, you can register for that one and they'll send you the code to be able to get the link. And then as far as our next sector meeting dates, we have our Just Walk meeting on September 20th at 8:15. If we don't have a slide for this, maybe I can just type it in the chat. Okay. I'll just type it in the chat. And if you want to go to the next slide, we can do the QR code for evaluations for today.
So Just Walk group meets monthly and our next, let's see, our next walk, we already said this Saturday, September 10th. But our next meeting will be Tuesday, September 20th. We'll be planning for the October meeting at that one, the October walk. And then the next healthcare sector meeting will be October 25th. So as Jody's putting all this in there, I'm just saying it out loud for you too, at 12:15. So that will be our regular sector meeting. We're waiting until after the Physical Activity Summit to host our next sector meeting. We want to see what additional learning might take place there before we meet again. And so with that, thank you all for joining us today. Please don't forget to complete your evaluations. You can scan that QR code on your screen. Keep
I
it
think
simple.
that Veronica said this is linking to the wrong evaluation. So she's going to send them out to us.
Okay. Well, don't forget to complete them once you get the evaluation.
Yeah, thank you so much, Dr. Bailey Davis, for coming and joining us today, and for all of you guys for joining us and for the great discussion. All right, bye guys.
Great. Have a great afternoon.
Thank you.